common causes are aspirations. So think about your vulnerable patients who come to us, say, from the skilled nursing facility. They're being tube fed, and somebody unfortunately puts the bed down flat while the tube feed's still running, and they aspirate, that kind of thing. Aspiration can be like our stroke patients who have difficulty swallowing, and they aspirate. We see that often too. So it can be from aspiration. Pneumonia, which can be community acquired. It can be from a lung contusion. That can happen from a fall down the stairs. You would see bruising on their anterior chest wall. So those are all direct lung injuries. What we see far more commonly in the hospital as far as ALI or acute lung injury is the indirect. Unfortunately, we see a lot of sepsis. And if you haven't cared for somebody with sepsis yet, I promise you will in the weeks to come. Which is why we have sepsis protocols in our hospital. So by far the most common cause is that massive transfusions, which was the case with the little lady I'm going to share with you at St. Mary's. Shock, pancreatitis, alcoholism, these are all other causes of indirect. So ARDS is typically a sudden, progressive process. So we had a patient at St. Mary's who was 60 years old, which is relatively young, and the closer I get to it, the younger it is. So she came in with acute and chronic respiratory failure. So what the hell does that mean, right? That kind of sounds like it contradicts itself. So what it means is this lady had a history of COPD, but came in acute failure. So she had an acute respiratory problem superimposed on her chronic problem. This poor thing, I'm going to just share with you her past medical history. Probably easier to tell you what she doesn't have, but none of the past medical history is going to surprise you in terms of her risk factor for respiratory failure. She has a history of heart failure, a long-standing history of heart failure. Again, she's only 60. She has a history of COPD, which places her at greater risk. She has a history of severe mitral stenosis. She had her valve repaired back in 2007. She, unfortunately, she has AFib. Even though she was anticoagulated, she did end up shooting a clot to her brain. She did end up having a stroke. And so she does have a little aphasia. And her stroke was on the left side. It was a left CVA, and I always remember left CVA language. That's all your language centers. So she had a little bit of aphasia. She was a diabetic. We had trouble with her blood glucose levels. They were, she kept getting hypoglycemic on us over the course of her hospitalization. But her problem with the anticoagulation was she kept coming back to the hospital. So this all started in probably mid-August. And she'd go home for a few days and come back. But what kept happening with her was GI bleeds from her anticoagulation. So the first time she came in with the GI bleed, she was vomiting coffee grounds. She was really, blood pressure was low, her heart rate was up, she was a little hypovolemic. They took her to the GI lab, they clipped the bleeder, gave her 3 units of packed cells, and sent her on her merry way. At that time, the cardiologist and the gastroenterologist agreed to hold her anticoagulation because of the GI bleed. Big, hard decision to make, because you know what happens when you hold anticoagulation in somebody with AFib who's already had a stroke, right? So we just kind of all hold our breath and hope she doesn't shoot another clot in the meantime, but we can't have her bleed out either. So it was a big decision, but cardiology was on board, GI was on board. Unfortunately, it was not communicated to the patient, who returned home and continued her anticoagulation therapy. You know the end to this story, right? It was ugly, So she comes back into the ED in hemorrhagic shock, bleeding. She ended up getting massive transfusions, and she had a very rocky course. She did a stint in ICU. They eventually stabilized her. She went out to short-term rehab for about a week, maybe a week and a half, and then ended up coming back to us yet again. And this time she came back to us with an acute lung injury from her massive transfusions. She was also in pulmonary edema, which was not a good thing. This patient had a 50, not 5, not 15, a 50-pound weight gain. She had, anybody ever hear the term anasarca?
Yes.
She had, just edema everywhere. And she was third spacing, so she had blisters. The fluid had nowhere else to go. It was seeping out of her legs. She had blisters on her legs that we were wrapping. She was falling at home prior to coming in, understandably. Obviously, they gave her some IV Lasix. Even though she's got the history of AFib, she did Brady down in the ED. Her heart rate dipped down into the 40s, so they did give her dopamine drip, which got her heart rate back up into the 90s. But one thing, and if you hear nothing else I say for the next hour, I can teach this in 2 sentences, ARDS and respiratory failure. It's refractory hypoxemia, which means hypoxemia that does not respond to supplemental oxygen. And I'll say it a million times so I know you have it, but refractory hypoxemia. And how do you think we're going to manage that if it doesn't respond to supplemental oxygen? Mechanical ventilation. So if you understand refractory hypoxemia is the problem, and we manage it with mechanical ventilation, you can close your books and go home. Because that's really what we're talking about for the next hour, all right? So this poor lady, she did not end up, I'm happy to say, that's the one thing that went her way. She didn't end up on a vent, but when she was in the ED, she did go to ICU. She came in static in the low 70s. And she had been at the cardiologist's office. The cardiologist took one look at her, sent her in, thankfully. She got to the ED. They had her on 10 liters. She still was static in the low 70s, so they decided to put her on CPAP. And if the CPAP didn't work, then her next step would have been to be intubated in mechanical ventilation. Thankfully for her, the CPAP worked. Now, over the course of the hospitalization, I don't know what, remember I told you she went for like a week and a half to short-term rehab. I don't know if she had a bad experience there. I don't know what happened, but the family, she and the family were adamant that she would not go back to short-term rehab. The family was taking her home with services. It took 2 or 3 of my students to turn her, because she's got all that fluid. She couldn't move. She had weakness on the right side from the stroke. So she was a challenge. We had to crush her pills, but ultimately we were able to wean her down on her oxygen, get her back to her baseline COPD. But you see how important communication is? Like this woman went through all of that because there was miscommunication about her anticoagulation. So I can't stress enough the importance of communication in our chaotic healthcare system and advocating for our patients. But she really is a shining example of everything we're talking about this morning, even though she didn't end up at the end on mechanical ventilation. But she was a lot. I'm sure the students and all our students took care of her during the day and evening shifts, and I'm sure they read her history and went, she hates me. Why did she assign me this patient? She hates me. But the patient actually was very pleasant and cooperative. The issue we had with her Tuesday and Wednesday was low blood sugars. She had to get an D10. She dipped down into the low 70s and got a little lethargic because the brain wasn't getting the glucose it needed. And then she perked right back up after she got the D10. But keep her in mind because she's sort of a classic example of ARDS and respiratory failure. And her COPD will certainly did predispose her. And her Lasix she was getting, if you're wondering, we were giving her 40 IV push Lasix in the ED in an ICU. When she hit the floor, she was put on 80 PO twice a day, and then they ended up upping her to 100 milligrams PO twice a day. That's a honking dose of Lasix. And guess what else she has? You're gonna know.
Heart failure.
Well, the heart failure, but what comes with heart failure? Decreased cardiac output from the heart failure when it doesn't get perfused. Renal failure. So she's got chronic kidney disease, and now, I know she's the poor thing. So you do that tap dance, like, even though we're up in the Lasix, and it was taking, she was diuresing. We took off, I think, 700 cc's. And they did order for her Foley to be DC prior, so they're going to discharge her today. So, you know, we gave 100 milligrams of Lasix, and then I said, pull the Foley. You know, you're going to be the unpopular kid on campus when you take the Foley out after giving somebody 100 milligrams of Lasix. Yeah. The next nurse is going to hate you. The doctor ordered it, so we did it. But so she diuresed, but her renal function, her BUN and creat did trend up a little. So you're always tap dancing, trying to get that right balance. If you give more Lasix, you make the renal failure worse.
I was just wondering, with the COPD, was she a smoker?
I don't believe there's anybody, I didn't see that. I don't recall seeing that in the chart. She's not a current smoker.
Okay, I was just
I don't
wondering.
recall seeing that in the chart.
Okay.
She came in, if you had to guess her ABGs when she came in, she was tachypneic, hypoxic, struggling to breathe, dyspneic,
Respiratory acidosis.
respiratory acidosis. Yep, she was tachypneic. Well, alkalosis originally first, but by the time, remember what I said, when they first start going into respiratory distress, they're going to be tachypneic first, they're going to be breathing rapidly, blowing off too much CO2. So they're going to have respiratory alkalosis, but then they start the increased workload of breathing. They start using their accessory muscles, those fatigue, and then they go into respiratory acidosis. So by the time she got to us, from the cardiologist's office to the ED, she was in respiratory acidosis. But then for James yesterday, she was in alkalosis, metabolic alkalosis, and I'm presuming it's the diuretics. I think we're worsening her renal function with the diuretics. And you're between a rock and a hard place with this patient because she was in pulmonary edema. How do you not give the diuretic? But yet when you give too much of the diuretic, you worsen her kidney function. So it's so hard to get that right balance. But she was very sweet despite everything. I don't think I'd be so sweet, I'd be grumpy, but she was very sweet. Okay, so the pathophysiology, basically, just like COPD, just like asthma, the underlying cause here is an inflammatory response. You don't have to know the mediators, but just know that inflammation is an underlying problem here. So just like asthma and COPD, we're going to give them corticosteroids as well, IV. There's damage to the capillary membranes, and it causes a shift of fluid into those little air-filled sacs, the alveoli, the end of the bronchiole. So if fluid fills those little air-filled sacs, obviously you can't have diffusion of oxygen in and exchange of CO2 out. So that's where the impaired gas exchange comes in. And as this happens, as this process unfolds, as the inflammation causes that fluid shift into the little air-filled sacs, it's going to adversely affect surfactant. Surfactant usually is what keeps our alveolar integrity intact. Once the surfactant function is impaired, then those little fluid and air-filled sacs will collapse. And on chest x-ray, the radiologists write patchy infiltrates. That's what it looks like on x-ray. So if you see that, that's all they mean by it. Bottom line is we have to oxygenate them. So, like this, just like this lady came in on 10 liters nasal cannula, it wasn't doing the job for her. They had to get her onto the CPAP. We also had a patient last night that was not assigned to my students. In fact, the students happened to just be at dinner at that point. So this gentleman came in with, trying to think of his story. So he was an alcoholic. He came in with DTs. He was an older gentleman, big past medical history. He was assigned to one of my graduates from last year, and he was decompensating. And I happened to bump into the graduate in the respiratory closet where we keep all our respiratory stuff. And she was reaching for a nasal cannula. And I said, "What are you doing? What's going on?" And I could tell she was frazzled. And she said, "Oh, I have a patient crumping." And I could tell she was upset and she was scared, which as a new grad, it's flipping terrified, right? To be in that situation where you've got to pull this patient back. And nobody was answering her. She was cortexing, how that goes. He was the answer guy. I said, listen, if it comes down to it and people don't answer you, you call the rapid. Don't play around, and then they have to come, right? But anyways, we're in the closet, and I said, well, what's his stat? She goes, oh, he's like down in the 70s. I said, oh, screw the cannula. We're taking the non-rebreather in.
Yeah.
So in we go with the non-rebreather. We pop it on. I tell her crank the oxygen up to 15, which she did. His stats came up. The problem with him was, even though we fixed temporarily his O2 stat, his blood pressure was like 70s over 30s. He was really decompensated. When I tell you, I'm white, but he like white matched the sheets white. He was white gray because he was bleeding. We think he had esophageal varices from his alcoholism, and he was bleeding. So we just moved our unit from the 3rd floor up to the 5th floor at St. Mary's. And the doctor's like, all right, get a bolus, 500 lactated rigors, which is a volume expander. That's what you do for somebody crumping, for somebody whose blood pressure is low. And I'll get it. I run to the bedroom. We had no lactated rigors. So that was delightful. It was one of those nights. We had a week at St. Mary's, I'll tell you. But he ended up going to ICU. But he did not end up being vented. They did do ABGs on him, but he was transferred to ICU. He was a full code. But he was another situation where the O2 plain O2 would not have done it for him. Even at 10 liters, it would not have done it for him. He really needed a non-rebreather. And if the non-rebreather doesn't work, then it's CPAP. If the CPAP doesn't work, then it's mechanical ventilation. Does that make sense, like the progression? Mm-hmm. Okay. All right. But that non-rebreather, it's like magic sometimes. Not always, but it was magic last night, thank goodness. It came back to us. All right, so hyaline membranes, this is, you would be tested on this, but hyaline membranes is like this sort of leathery fibrotic changes that happens to the inside of the little air-filled sacs, and it just further reduces the gas exchange at that level. Okay, so there's fibrotic changes in the lungs, there's less surface area for gas exchange, the hypoxemia becomes resistant even with supplemental oxygen. So on the second bullet here, just write refractory hypoxemia, because that's really the definition of it. It's hypoxemia that doesn't respond to supplemental oxygen. And again, our management is going to be, worst case scenario, mechanical ventilation. Hypoxemia. Hypoxemia. Refractory hypoxemia. It doesn't respond to supplemental oxygen. Yep. So if it doesn't respond, if it continues to not respond to supplemental oxygen, again, the progression is going to be, you're going to up the supplemental oxygen. They don't respond to it, you're going to move to the CPAP. If they're still not responding to it, that's refractory hypoxemia. Then you've got to go to mechanical ventilation. Is there a question? Okay. So sepsis again is the most common cause with sepsis, septic shock. We see multiple organ system dysfunction, or what we call MODS. We're going to talk about sepsis with Professors Brada and Kelly in a few weeks. But that is, again, a common cause of ALI and ARDS. This I just put in for visual learners. I just thought it was a good visual of the pathophysiology. It really just shows there's a change in capillary permeability. There's a shift of fluid into the air-filled alveoli. You can see the fluid there shift. And eventually, it'll adversely affect the surfactant, and those little air-filled and fluid-filled sacs will collapse and cause atelectasis. In terms of etiology, about 200,000 Americans are affected by ARDS each year. I don't have the most current numbers. I would presume they would be higher because of COVID. Remember, we talked about COVID sort of out of bad comes outcomes good. I can tell you we learned a whole lot about ARDS and respiratory failure due to COVID, and I'll talk more about that when we talk about proning patients who are on ventilators. The 33% of hospitalized patients who had COVID, of that 33%, 75% of them landed in ICU with ARDS. The mortality rates range from 25 to 45%, so it's serious. Those are high mortality rates. Mortality rates tend to be a little higher in men than women and greater for African Americans. Patients who develop ARDS from sepsis have poorer outcomes. And understand, and I'll say this repeatedly, understand that mechanical ventilation is not the cure for ARDS. It's really the bridge. It's just we have to figure out what caused the ARDS. We need to figure out the underlying cause, treat that, manage that, and then hopefully wean them off the vent. So it's really just a bridge to get them treated, to get the underlying cause treated, corrected, and then we want them off that vent as soon as possible. In terms of risk factors, individuals with pulmonary infections such as COVID is obviously a risk factor. Again, a patient population who should be vaccinated with the big three. I call them the big three: the pneumonia, the influenza, and the COVID. Individuals who aspirate gastric contents, again, think about your people with their G tubes and or your stroke patients who have trouble swallowing. Inhalation injuries, these are like smoke inhalation, that carbon monoxide poisoning that's associated with smoke inhalation, which is lethal, and then salt water near drownings. And I'm sorry, I didn't mean to look this up and I didn't get to it, but salt water, I did read in the literature that salt water near drowning is worse in terms of outcomes than a near drowning, say in a pool or in lake water. I'm presuming because of the sodium, it must cause more shifting of the fluid into those air-filled sacs, but I know that the outcomes are worse for salt water near drownings. Indirect insults, overall body sepsis, again, this is just a repeat slide, traumas, GI infections, multiple blood transfusions, as was the case with our little lady at St. Mary's. So again, aspiration, smoking may increase risk, yet another reason to quit smoking, right? Like we needed one. In terms of clinical manifestations, we talked a lot about the importance of reducing the workload on breathing.
What causes the blood transfusions? What causes it to put a patient into ARDS?
For this lady, it put her into pulmonary edema, which then put her into ARDS and respiratory failure. Yeah. 50 pounds, think about that, 50-pound weight gain. And we didn't take, I think we only took 10 pounds off, which isn't, for all the diuretics she was getting, that's not a lot of weight.
It's not per se the blood.
No.
You know what I mean? It's the volume.
It's the volume, yeah, volume overload, yep. So we've talked a lot about reducing the workload of breathing. Somebody with ARDS is going to come in. Initially, as we've said repeatedly, they're going to come in initially to tachypnea, breathing rapidly, blowing off too much CO2. If we withdraw the gases, they would be in respiratory alkalosis, but they rapidly decompensate. When they start using those intercostals and they're really working hard to breathe, eventually those muscles, as we've said many times, get tired too, just like our muscles fatigue, right? If we work out or do strengthening, our muscles fatigue. So the muscles required for ventilation fatigue too. And when that happens, that's when their respiratory rate is going to decrease and they're not going to be blowing off CO2. Instead, they're going to be retaining it. So we're going to see PaCO2 levels above 50. This lady was in the 60s, the mid-60s. And when we draw the gas, we're going to see severe hypoxemia. So I'm talking down in the 50s, sometimes even in the 40s, right? So remember that combination when you're looking at an ABG and someone like the patient we discussed earlier. If that PaCO2 is in the 50s, and if the PaO2 is also in the 50s, the patient really needs help with ventilation. Now, whether that's CPAP CPAP or a mechanical ventilator will be determined, but they are working way too hard to breathe. We need to help them with ventilation. If you were to listen to their lungs, you would hear rales and bronchi. The chest x-ray is going to show those patchy infiltrates. We're going to obviously be doing continuous pulse ox on them and frequent ABGs. They're going to go to ICU where they're going to have an arterial line where we can pull ABGs off frequently without sticking them 1,000 times. All right, so again, the hallmark of ARDS, refractory hypoxemia, and we're going to manage it with ventilatory assist. They will have mental status changes. That should make sense if they're not oxygenating their blood. Their brain's not getting the oxygen it needs. Remember, the brain always needs a lot of oxygen and a lot of glucose to function normally. Okay, so when the patient is in ICU, and even on the floor, but especially in ICU, bless you, this is typically the team you'll see. So certainly the critical care nurses work hand in hand with respiratory therapy. As far as the mechanical ventilators go, respiratory therapy takes most of the responsibility for them in the ICU. As nurses, we're concerned with the common alarms, the ones that are easy for us to fix. Typically, if a high alarm goes off in a mechanical ventilator, it means that there's a blockage somewhere. Most commonly, they just need to be suctioned. So high alarm, typically you suction them, the alarm will go off, that'll resolve it. Sometimes the patient's biting down on the tube, we might need to sedate them a little more, but usually it's suctioning. The low alarm, and how I remember it, is the low alarm is from a leak. There's a leak somewhere in the system. So just remember low leak, all right? So there's a leak somewhere in the system, you just go back like we always do with any tube anywhere in a patient. We always go back and follow it to the patient. We see where the loose connection is, we tighten up the connection, we're good to go. In the worst case scenario, if your ventilator, for whatever reason, craps out, what do you do as a nurse? Get back. Yep, get back, yeah, move back, yep. All right, so the diagnostic test, nothing new here. The ABG analysis, the chest x-ray, we're trying to figure out, did a pneumonia cause this? Do they have some sort of trauma, contusion? What is this from? Do they have fluid in the lungs? Our lady, we did determine was pulmonary edema. We do a CBC to see how that white count's trending, to see if there's an infectious etiology, which we can manage with IV antibiotics. And blood cultures, obviously, so we pick the appropriate one, as well as sputum. So again, mechanical ventilation is just buying us time. That's all it's doing. It's buying us time to figure out what caused this and fix it. And then as soon as we fix it, we want to get them off the ventilator. So some of the pharmacotherapy, there is no one effective drug therapy that treats ARDS specifically. But we do use nitric oxide only in adults, not pediatrics. And this helps reduce the intrapulmonary shunting and improves oxygenation. And then remember I said the inflammatory process interferes with the function of surfactant, which normally maintains our alveolar integrity. So we give surfactant therapy as well. And then because the underlying cause is inflammation, we're going to give them corticosteroids. In terms of complications, where to begin here, right? A common one is because when they're in ICU, they have an arterial line. Yes?
Sorry, is this surfactant therapy, is that the corticosteroid?
No. Surfactant is actually replaces what your body would normally make for surfactant to keep the alveolar open, the alveoli open. Okay, so when they're in ICU, they have 5 million catheters, so they do unfortunately get infections of their lines. So we're always assessing the lines, the insertion sites. Respiratory ventilator-associated pneumonia, or VAP, occurs, I'm sorry to say, in 68% of our patients on ventilators throughout the country. I hate that number, but I'm going to tell you about a VAP bundle that hopefully is going to bring that number down, because too many of our patients on vents and ICUs are getting this pneumonia, which then increases mortality rates. GI, we give anti-ulcer drugs. Remember, this is a time of fight or flight for them. So a normal stress response, they are in a, bless you, hypermetabolic state. So they are blowing through all of their stores. They are losing weight. In addition, when we are in fight or flight, our body at a cellular level flips over to anaerobic metabolism, and there's a buildup of an end product called lactic acid, right? So one of the things you're going to see on your patients with ARDS, with sepsis, with COPD, is they're going to draw lactic acid. And that's just another lab value we look at, and we kind of trend to see how they're doing over time. So with GI, our poor lady, with GI anti-ulcer drugs, so Protonix, usually IV push, we want to turn off that acid production in their stomach. Renal, they can have an acute kidney injury. It actually can be imposed on a chronic injury as well. So their renal function is going to be impaired, most likely due to decreased cardiac output. And we're going to look at how their BUN, creat is trending, and we're going to look obviously at their urinary output. So again, they're in a critical care environment. They're going to have hourly outputs done. We could never do that on the floor, right? We could never monitor somebody that closely on the floor. And in ICU, even on the floors, we have scales in most of our beds to do daily weights on them to evaluate their renal function. We're also going to look at all of their electrolytes, because if their kidneys, remember kidneys just filter the toxins out of our blood, right? So if they're not working, if they're not filtering the toxins, the electrolytes are all going to be out of whack. So if they're hypokalemic, if they have a low potassium, we're going to give them a few rounds of potassium to bring their potassium level back up. If their magnesium's low, we're going to give them a few rounds of IV magnesium. So the bottom line is really just correcting the electrolyte imbalances. Cardiac dysrhythmias and decreased cardiac output. Again, they're obviously going to be on telemetry. Even when they come to the med-surg unit from ICU, we will keep them on telemetry because of our concern for dysrhythmias, because their electrolytes are all screwed up from their renal issues. Hematology, they are anemic. They will most likely be getting blood transfusions. And then central nervous system, they do have sleep disturbances and PTSD, because it's very scary to be ventilated, I can't imagine. And well, they are sedated though, because otherwise they would fight the vent, but you can control the level of sedation. And then as we're getting ready to wean them off, we back up on the sedation so they're a little more awake. But we don't want them fighting the vent either. Okay, so ventilator support, there's various types of ventilators. There's the negative pressure, and this one creates negative pressure externally, which draws the air in, the chest outward, and pulls air into the lungs. What you'll see more commonly is the positive pressure ventilator. And examples of non-invasive positive pressure is your CPAP and your BiPAP. CPAP continuous starts with a C, remember C continuous. Bi is 2, so just remember inspiration, expiration. And the non-invasive, obviously they cannot have food. If they had food in their mouth, it would be pushed into their lungs. That would not be a good thing, so they are obviously NPO. Our lady was getting CPAP. Respiratory would come at night and put her CPAP on at bedtime. Some people need it during the day too. Our patient did not. We always try to prevent endotracheal intubation because mechanical ventilation actually can cause damage to the lungs as well, so we do try to avoid it as best we can. Not always feasible, but we try. And I think that's all I want to say there. And that's just a picture of it. I know you probably have the same slide with Professor Prada in her talk about respiratory equipment. All right, so ventilatory modes of ventilation with the positive pressure. For the PEEP, it's just end expiratory pressure. All you really have to know here is that we use it to treat ARDS. It reduces hypoxemia. That's really all you need to know about PEEP. You would learn more if you worked in ICU. But for an entry-level RN, that's really, you just need to know that in general. Yeah, it reduces hypoxemia, and we use it to treat ARDS. And if you know that much, I'm happy. The pressure support vent delivers vent-assisted breaths. So what that means, vent-assisted breaths, is like the vent is doing a little bit of the work, but the patient's also doing a little bit of the work. So we can use this usually when we're trying to wean a patient off the vent. So the patient's actually doing a little bit of work. We can see how they tolerate it before we take them off the vent entirely. And then pressure control ventilation, this one is just what you think of historically of ventilation. The vent is doing all of the work, and we have to sedate the patient so that they don't fight the vent. And it's usually pretty heavy sedation. Oh, sorry. Okay, so ventilator associated pneumonia, again, is a major problem. And there's a bundle, I don't know why I don't have it on this. These are complications associated with vent. So the VAP, the ventilator associated pneumonia, I'm going to come back to that on a slide in a minute. Barotrauma is actually damage to the alveoli. They can hyperinflate and rupture. Pneumothorax is a collapse of the lung, which we'll talk about before you leave me today. And then cardiovascular effects, that's all that decreased cardiac output, the renal problems that go with it. And GI effects, again, is the stress ulcers, the bleeding, so we give them the protonics. Even though we're giving them protonics, we're still going to check their urine. For blood, we're still going to make sure they're not bleeding in their stool because they are at high risk for GIP, especially when you look at all their comorbidities, like the patient we talked about earlier. Okay, so endotracheal tubes are placed in the patient's throat. Again, can be done by a respiratory therapist. For those of you who are interested in nurse anesthesia, and it's really good money, it's really good money. But you have to live home while you're going to school. If you have, my father's 83, he's not taking me back anytime soon. But it's a great role. Yes.
I'm sorry, the barotrauma, can you repeat that again?
The barotrauma is when it does damage to the alveoli, causes them to rupture, it hyperexpands them, causes them to rupture. So if you're interested in anesthesia, that is, you will learn to manage airways. You will learn to intubate patients. You will learn to manage their airways. If anyone has an interest in that, it is a great role. Other than that, it's respiratory therapist that does it. If respiratory, for some reason, has a hard time intubating someone, then you'll hear anesthesia called overhead. Anesthesia, they are the pros. They will get even a difficult person to intubate. They'll get them intubated. Paramedics intubate out in the field as well. Tracheostomy should be done on anyone who's been on a vent for more than 10 to 12 days. They should really do a tracheostomy. And a big part of our nursing care, as you now know, is to maintain patency of that airway. So we are going to be suctioning them as needed. For those of you at Hospital for Special Care and probably Gaylord, You see that they have the mist over their trach, some of the patients. That's just so the mucus doesn't dry out. They can get mucus plugs that actually block their airways and put them in respiratory distress. So they may get a little humidification over the trach to avoid mucus plugging. Okay, so the Swan-Ganz catheter is something you will not see on a med-surg unit, but for those of you who work in ICU and critical care, you will see Swan-Ganz catheters. This is really the only way we could definitively monitor somebody's cardiac output. It gives us really valuable data to tell us how well the pump is working. It tells us if our patient's hemodynamically stable or not. And the nice thing about the catheter is the decision to, get the patient back to the med-surg unit and home is usually made on how hemodynamically stable they are. Patient cannot leave our ICU if they are not hemodynamically stable. They should never be sent to the floor unless they're stable. The arterial line is great. Again, you're not going to see it on your med-surg floor. You're going to see it, for those of you at St. Mary's going to ICU in the coming weeks, you will see it in the ICU. You'll see both of these lines. The arterial line is great for drawing all those ABGs and really getting a sense of how well our patient is doing in terms of their respiratory status. We draw electrolytes frequently on them because of our concerns about the renal function. Obviously, I&O in ICU, that's done hourly. They have equipment that drops the data in automatically for them. Daily weights we talked about, and fluid and electrolytes we talked about. They may have enteral or parenteral feeding, so they may have either TPN, total parenteral nutrition with lipids, and or a G-tube with enteral feedings. That's the physician's call, basically. Sometimes they'll put in a jejunostomy tube. It's just a little lower down in the anatomy, and there's a lower risk for aspiration with that one. But regardless of what setting you work in and you land in a few months, it's going to come quick, I promise. I know, if only it was here. Whatever setting you work in, when you have a patient with a continuous tube feed, I beg you, never ever with a continuous feed, put a patient flat. Never, never. They will aspirate for sure, and it'll cause all kinds of problems. So either you stop the feed if you need to change the bed, but you can change. I don't know, do they even teach you bed making in the first year at all anymore? Mm-hmm. They do. All right, so when you were taught to make an occupied bed, you know how you put them on their side, you put the sheet on, you kind of roll it, you tuck it under them. You could make a bed from the top down too. So you can just roll it sort of behind them, lean the patient forward. So you don't have to put them flat, somebody who's having a continuous tube feed. It's magical. It works. I don't know that I thought of that. I can't take credit. I learned that probably from a seasoned nurse, but like we all learn, right? So I'm going to say this again. I've said it several times, but another good thing that came out of COVID, and not much good came out of COVID, speaking of which, I'm going to ask you all to say a little prayer. My son is in Italy, and I think he has COVID. So I said to my husband, listen, I might be hopping a plane to Italy because he's my one and only. My husband's like, he's a grown man, he's 30. You gotta let go a little. He's with his girlfriend, they take care of it. I'm sure she'd really love me showing up. But I am a wreck. I'm a wreck about my baby. They're always your babies. So anyways, COVID, what we learned from COVID, and we learned this the hard way, in ICU they used Prony. It's been used for a long, long time, many years. We never really understood the value of proning a patient. That's putting them on their bellies, face down, when they're on mechanical ventilation. We had no idea how valuable it was until people really started, the death rates really soared with COVID. And as the death rates got higher and higher, everything they were trying to do in ICU, all our old tricks weren't working. People were dying left and right. And it was sort of like the Hail Mary pass. It was like, I don't know, let's just try proning them more and see what happens. And so they did, and the outcomes were really good. And I think, you know, again, for those of you who went up in ICU, it's probably going to be a standard of care. They do really well with proning. It helps oxygenate the dorsum of their lungs, and it dramatically reduced their mortality rates. It was the game changer. That was really, I think, the game changer for our critically ill patients. Do we have anybody that works in ICU here? Anybody at PCA? Have you ever, can you share anything about, you know, proning them, sort of?
No, we haven't proned anyone really.
Okay.
Yeah, I've heard them talk about it though, that like when during COVID, they literally, as soon as they finished turning everyone, because they had to reduce bed sores and whatnot, they had to start again.
Yeah.
Because
they're prone 3 to 4 times a day. Right.
yeah, so.
And it's hard to turn them
Yeah.
because of their 5,000 tubes.
Yeah, they're not helping at all.
Yeah, they can't help, right, right. So when they're prone, when they're in that position, what happens is it's just gravity. So fluid will settle down, like their face down basically, and fluid will settle in their face. And then when you turn them back over, their face doesn't look like their face anymore. They look all distorted. So just if the family is coming in to see them after we've just repositioned them after proning them, I just always prepare the family for that. They're gonna look different to you. It's edema, it's gonna reabsorb, you know, and they'll look like themselves again. But very upsetting for family to see their, you know, their loved ones that way. But it was the game changer. It really saved a lot of patients. I did include an article. He's not going to test you on the article, just if anybody has an interest in proning. I did include an article in Blackboard for you, like you have time. But someday when you have time. And then ECMO. This was the other game changer. Again, ECMO had been around for like 70 years, but we weren't using it that much until COVID. It was the same thing. We're like, well, let's try it. So basically, just think of it as like, it's similar to the heart pump, the bypass you put people on for open heart surgery. It's basically like artificial lungs. So it's going to provide oxygenation, and it's going to get rid of the excess CO2. And ECMO has been, I don't know if anybody remembers in the height of the pandemic, people were going crazy trying to find ECMO machines for their loved ones. People were, you know, traveling to other states trying to find ECMO for their loved ones. As I've said repeatedly, the vent is not the cure. It really is just buying us time. We've got to correct the underlying cause. We have to be careful with our fluid replacement, and they're going to be on either low molecular weight heparin like Lovenox, or they'll just be on regular heparin, 5,000 units, either or, to prevent clots, because they're obviously not mobilizing. So the goals of ventilation are to support them until they can breathe on their own again. Doesn't cure those lungs, it just, again, buys time. The trach tube, again, if they're going to be vented for more than 10 to 14 days. The warm, humidified air, just to prevent those thick mucus plugs from polluting airways. And then the VAC, the ventilator bundle. This is really important. This is the individual this is across the board. This protocol is done, it's evidence-based, it's based in research. So every ICU should be doing this with every patient who's on a vent. And it's common sense stuff. Nothing here should surprise you. Head of the bed up, that right makes sense. Head of the bed up 30 to 45 degrees. Daily sedation vacations. So this is when we back them down on the sedation to see how they do, if they're kind of getting ready to come off the vent. Peptic ulcer prophylaxis, any time of stress, patients at increased risk. So they will be getting pantoprazole or Protonix. IV push, that turns off acid production in the stomach. DVT prophylaxis. These are all standards of care. And chlorhexidine mouthwashes, because that when somebody is tubed, that sort of all of their protective mechanisms are gone. They can't really cough, you know, they can't clear their own airway, so they are at greater risk. They can aspirate on their own oral secretions. So mouth care is critically, I know we kind of undervalue mouth care, but it's critically important for them, and we do it with the chlorhexidine.
We're talking about the reason for the chronics
Yes.
and why.
To turn off, because when somebody has, it's a fight or flight response, it's a compensatory response, they go into a hypermetabolic state, there's an increase in hydrochloric acid, and they're at greater risk for a stress ulcer. Yep. Okay.
Thank you.
You're welcome. So children, pediatrics, I guess the one other good thing about COVID is it spared our kids, it spared the pediatric population, which I guess was a good thing. There thankfully is a low incidence of ARDS in pediatrics. Where we see it more commonly is kids that fall into the pool, near drownings, or kids that are at the beach and have near drownings, that sort of thing. Generally more prevalent in kids who are immunocompromised for some other reason. They have some underlying chronic condition that places them at greater risk for infection in general. In terms of physiologic differences, their chest walls are more compliant than ours. They have higher sedation requirements. They're not simply little adults. We do need to treat them differently. And their little lungs are not fully developed. The standard treatment that we use for adults, remember we talked about the nitric oxide, the surfactant. We don't use that routinely in pediatrics only because we don't have research that supports it yet. That may change in time, but right now we don't do that routinely in that population. We need additional research. And then, the vaccination, as we've talked about many times, the standard 3. As far as pregnant women, their mortality rate is high. It's generally an obstetric complication if they end up in ARDS. And this is another population we don't have a lot of research on. They are, when they're in ICU, they can be proned, but when you're proning them in the 3rd semester, obviously they have to be on continuous fetal monitoring. But we do it, they have to be very closely observed when they're proned in ICU, when they're in respiratory failure or have ARDS. So again, ventilatory support, we want to get them off as soon as possible, and close fetal monitoring. In our older adults, as we've said many times, they're at higher risk for mortality because of their comorbidities. Their chest walls are not as compliant, they're a little stiffer. The research indicates that for whatever reason, they are less apt to be aggressively managed for their ARDS. The research seems to point to a bias on the part of healthcare providers. I understand that both ways. There may be a bias, but there's also the other side of that where you have people, because our healthcare has gotten so good and our technology's gotten so good, we have people in their mid-90s, high 90s on vents in the ICU, and then you can't get them off, and it's awful. I mean, it's just an awful situation. So I get both sides of this, but in general, research indicates they tend to not be as managed aggressively as the younger populations. Treatment here is a prevention of non-pulmonary organ complications to improve their outcomes, and then obviously managing their nutrition and their oxygen levels. In terms of nursing process, our role is to always, whether they're on the med-surg unit in our ICU, our role is always ABCs, right? So always make sure the airway's patent and make sure they're ventilated, make sure they're breathing. Count those, count the respiratory rate. Listen to those lungs. Changes in level of consciousness is an earlier sign that your patient's slipping into trouble because that brain is not getting the oxygenated blood it needs. So that's kind of an earlier indicator that they're maybe not ventilating as well as we'd like. And then in terms of your assessment, in history taking, we do look if they've had previous problems that predispose them to complications. any current illness that may have contributed. And then the physical assessment, I'm not gonna read to you, but that's pretty straightforward. The nursing problems, this would be for your clue, boxes, pages. Just take a moment to look at these. These should make sense to you. In ICU, the confusion, I don't think we talked about it. Did you ever hear of ICU psychosis? Yeah, you're nodding your head, you have. It's a syndrome where somebody in ICU, because they're critically ill, the lights are bright all the time because you have to assess their skin, their color, they've got all these lines. So the lights were bright 24/7, and the person in the bed loses track of time passing. They have no sense of if it's day or night, and it disorients them and causes a psychosis. They lose touch with reality. So one of the things that you'll see nurses in ICU do now is they do dim the lights. They're always orienting the patient to try to reduce their risk for ICU psychosis. Very upsetting for the family. The patient's not necessarily aware of it, but it's very upsetting for the family, ICU psychosis. Airway clearance, that makes sense, right? And what alarm goes off again on the vent if they've got a? The high, good. And how do we remember the low alarm? Leak. Good. You're going to do what with the leak? Check your connection. Check your connection. Okay. Breathing pattern ineffective. Does this make sense, guys? Gas exchange impaired, increased cardiac output, imbalanced fluid, dysfunctional breathing. I'll talk about that in a minute. Nutrition. These should all make perfect sense. All right. I'm not going to read this to you. That's pretty straightforward stuff. Do you need a stand-up break? Keep talking. Shut up and keep talking. Lab work, in terms of the lab work, obviously ABGs, electrolytes, all that good stuff. Vitals are hourly only in ICU. If somebody ever tells you on a med-surg unit, you need to do neuro checks hourly, you need to do outputs hourly, you need to do vitals hourly, you say, no, that is not the level of care that we can safely provide here. This patient needs to be in another. And if somebody doesn't support that, that's where you go to your manager or your charge nurse first, and then your manager or your supervisor. Because if somebody needs that frequent monitor, they have no business being on a med-surg floor. And I'm just telling you this because it's a little chaotic out there at this point in time. So you need to advocate for yourselves. Protect that license you're working so hard for. Oxygenation status with ABGs, their neurologic status, this is all stuff we talked about. Provide analgesia, anxiolytics, and sedation. Beta agonists, just like how we always maintain our patent airways. Keep the bed up, proning 3 to 4 times a day, and then suctioning as needed. All right, these are, again, everything we talked about. The hemodynamic status is only done in ICU with the Swan hands. Monitor the renal function, INOs, weights, it's all repeat stuff. Administer fluids as needed. And be careful to avoid fluid overload. Maintaining a patent airway. This is postural drainage, which again, respiratory therapy will do. That's the one where they're repositioned about every 10 to 15 minutes. And just by virtue of gravity, it gets all the mucus in the smaller airways into the larger airways, or hopefully they can get it out themselves. We're going to culture their sputum. Again, we have to figure out the cause. That's like major. We have to figure out the cause and correct it. And then if they have an endotracheal tube, it has to be secured properly. And we may have to restrain their hands if they're trying to extubate themselves. If they're trying to pull the tube out, that's the normal knee-jerk response, is to try and get whatever's in their throat out of it. We want to promote ventilation, high fowlers. They're going to be upright. You're going to be meeting their ADLs. I mean, if they're critically ill and they're that compromised, obviously, you are doing everything for them. You are doing the fluff and buff. You're doing everything. Assess and document their respiratory status and report any deterioration and give oxygen as ordered. And so last night when we had that patient crump on us, we cortexted the doctor wasn't answering. we're not gonna let the patient, cope, right? We have to do something in the meantime to support the patient, and we did, and then the physician did come to the floor, and the patient did go to ICU. Cardiac output, monitoring their level of consciousness, seeing how the brain is being perfused. Their pulmonary artery pressure, again, that's cardiac output only done in ICU. Their heart and lung sounds, we're gonna listen to like we always do when we do our head to toe assessments, weigh them at the same time every day. This is kind of all routine stuff. Give analgesics and sedatives as needed. So if the patient is not weaning off the ventilator well, they're basically going to have all the symptoms they had when we put them on the ventilator. It's kind of like a recurrence of those symptoms. So they will have worsening dyspnea. It just means they're not ready to come off yet. We'll try them again either in a few hours or the next day. But if we try to take them off and they get really dyspneic on us and apprehensive, they've got to go back on the vent for a little bit. If we try to wean them off and their O2 level plummets, they're not ready to come off the vent yet. What do we call that? Refractory hypoxemia, right? So if we take them off the vent and try to get them onto a lower level of oxygen, and they get hypoxic on us, they have refractory hypoxemia that doesn't respond to the nasal cannula or the non-rebreather or the CPAP, then they've got to go back on the vent. Cyanosis, pallor, diaphoresis all indicate they're not oxygenating well, they're not ready to come off the vent. Diminished breath sounds, accessory muscles. We know if they're using accessory muscles, they're working way too hard to breathe. We've got to help them with ventilation. Decreased level of consciousness, that's the impaired gas exchange. Brain's not getting all the oxygen it needs. Remember, the brain's greedy, needs lots of oxygen and lots of glucose. And then worsening ABG values and shallow gasping breath. Paradoxal breathing. So normally, paradoxal breathing is like normally, and you can go ahead and do it, take a breath. When you take a breath and you breathe in, your chest goes out, and then when you exhale, your chest goes down. Paradoxal breathing is the other way around. And it's not going to ventilate the patient properly. They have to be back on the ventilator. They're not ready to come off yet. Very stressful, as you would imagine, both for the patient and for the family to be on a ventilator because you have a tube in your throat. When we start getting them ready for weaning and we start doing the sedation vacations, the patient is alert, can hear and understand what's going around them. So we always ask the families, please don't have sensitive conversations in front of your loved one. They're there, they can hear you. So please, be careful about what is said in their presence. And we do allow family, not through COVID, unfortunately, families were kept from their loved ones, but now they're allowing visitors to come back in, thank God. That was horrible for families. And really a lot of the PTSD that we see in our young nurses and seasoned nurses too, and respiratory and the PCAs, anybody who worked in ICU through the pandemic, they have PTSD. They have legit PTSD. They were so traumatized by what they experienced in that environment throughout the pandemic. Visitors were not allowed. And think about that for a minute. Like if your loved one was in that bed and was not going to make it, and somebody was telling you you can't be there to hold their hand or be there to be, I can't imagine. Like I said, my dad's 83 with asthma, and I told my husband, you may have to come get me out of jail because I'm going. I'll put my lab coat on and make a run for it. I'm going. I'll be the code gray they're calling. I'll be the one they're doing the takedown. So it was traumatic for families too. And what was happening was the PCAs and the nurses were literally holding up an iPad so families could say their goodbyes to their loved ones. It gives me goosebumps. It's just very, very traumatic for them. So frequent family visits, hopefully as we move out of the pandemic, will resume because they are so critically ill. It's good to have family there. We try to explain just in basic terms what all the beeping and alarms are, what the equipment is doing in a very basic way. Sometimes Patients, families need to understand that on a basic level. It gives them some sense of control because you feel very powerless when your loved one is critically ill and you can't fix it. We allow them to participate in care. I don't know, feel them out. There's some families that are like, oh, hell no. No, I don't want to do this. But there's other families that like just dive right in with you. They're like, oh no, I'll, wash up with you or whatever, turn. So feel the family out in terms of their receptiveness to help. Again, if they're willing and able to help, I do encourage it because I think it helps with some of that powerlessness that they're feeling, that their loved one is so ill and they can't do a thing about it. All right, preparing for discharge. They're going to get lots of referrals, PT and OT. They're probably going to go to short-term rehab for a stint, and then back home with services. They will be taught about ARDS and what the symptoms are so they know when to contact their healthcare provider. We need to tailor activities, have them pace activities, assist as needed, avoid smoking, that's sort of common sense, being around smoke. And then, as I've said 5,000 times, immunizations and avoiding sick people. I do think that was sort of another good thing that came out of COVID was if you're oxygen dependent at home and you're really sick and you're really compromised, I think for older folks particularly, this ability to order your groceries online and go to the store and park in the designated spot and have somebody put your groceries in the car, I think was really life-saving for them. I don't know if it's going to continue beyond the pandemic, but I think right now it's a really nice service. And that, I don't know the name of it, is it Instacart? Is Instacart the one where you kind of do the same thing, you order your stuff and they bring it? Do I have it right? Yeah. So I think, again, if you're compromised, it's a nice option. You don't have to worry about going out to the grocery store in the height of cold and flu season and getting an infection that can land you into ARDS or respiratory failure. Okay, I'm not going to read these to you, but these are the expected outcomes. I've included them again for your clues. And then the drug therapy goals, giving bronchodilators, just like we do with asthma and COPD, are the same reason. We've got to get the airways open. Reduce their inflammation with steroids, as we've said 500 times. Reduce their pulmonary congestion with diuretics. Nothing new here. Pain and anxiety we're going to manage like we always do. In ICU, when they're on the vent, they'll be on propofol. And then when they're on the med-surg unit, we'll get them onto some benzodiazepines, lorazepam, and opioids if they have pain. And then azithromycin and ceftriaxone or Rocephin. These are the two rock stars that treat respiratory tract infections. They do a really good job of covering gram-negative and gram-positive organisms. They're the big guns, and they work well. Okay. Talk a little bit about pneumothorax. So a pneumothorax can be as in the picture here. Oh, this is, you're looking around, do you not have the slide? Oh, you have it, okay. Okay.
I thought it was a
Oh.
or something.
Oh, you didn't realize it was a knife? Oh.
Yeah, I thought it was like a skin or something.
Yeah. Knife, unfortunately.
I know, who took the picture?
Wasn't me. All right. We're almost done. We're almost done. Pull it together. All right. So acute lung injury, in this case, this is a knife wound, obviously. So it's very obvious to us what caused the lung collapse here. If this rolls into your ED, do not ever, I've said this before, but I'm going to say it again because it's important, don't ever pull it out. Never pull it out. Support it with some sterile 4x4s around it because patient's going to the OR. And it'll be removed by the surgeon and they'll place the chest tube at the same time. These can also happen from, so that knife wound is the obvious cause of a collapsed lung, but they can also happen from what we call a blunt trauma to the anterior chest wall. You won't see, like, in the old days, I'm gonna say when I started driving, we didn't have airbags. So we used to get a lot of blunt traumas and a lot of pneumothoraxes because people's chests hit the steering wheel in motor vehicle accidents. But now, because of airbags, thankfully, we don't see that blunt trauma. The blunt trauma that we see can be from, unfortunately, from domestic violence, someone who was pushed, shoved, slammed to a floor, that kind of thing. Or just an elderly person who took a bad fall, down some stairs. So it can look like just bruising on the chest wall, and you think, oh, that doesn't look so bad. What's happening beneath that is that the lung is collapsed and they're in trouble. When the lung collapses, as you would imagine, if you were to take the diaphragm of your stethoscope and place it over that lung field, what are you going to hear? Nothing. Nada. You hear no breath sounds. So what happens is the air enters that pleural cavity. You have the visceral, what am I trying to say, guys? Visceral, parietal. Parietals around the cavity, viscerals around the lung. Pleural, thank you. So the visceral surrounds the lung, parietal the cavity. There's a little bit of fluid in between normally, just a little bit, to allow the lungs to expand and contract. And it prevents like a friction rub. But what happens in a pneumothorax is air gets into that space where it doesn't belong, and there's loss of negative pressure, and the lung collapses. The treatment for it is insertion of a chest tube, or two. You have patients that have two chest tubes. We had a patient at St. Mary's yesterday. I guess we really didn't have a good week at St. Mary's. I'm almost embarrassed to tell you this story now. But it happens. This happens. We had a older patient who had a lung nodule. They went in to biopsy it. This does sometimes happen though with biopsies, and unfortunately her lung collapsed. So she had to have a chest tube. She had it in her right apex. Remember, the right lung has 3 lobes. She had it in her right apex. So we assessed her. She had a dressing to it. We assessed the integrity of the dressing. We palpated around it. What were we palpating for, guys?
Crepitus.
Subcutaneous emphysema, right? And what does it feel like? It sounds like Rice Krispies feels, yeah, kind of spongy, right? It feels spongy like when you get something wrapped in the mail with that bubble wrap. She did not thankfully have subcutaneous emphysema, and then we did what you always do as a nurse. We followed the tube from the insertion site all the way down to the collection device to make sure it wasn't kinked, to make sure that it was draining properly, and she was draining serosanguinous fluid. And then at the end of our shift, we put a mark where the fluid line is, so the next shift knows how much she drains for the next, we'll do 12-hour shifts at St. Mary's, so for the next 12 hours. And I don't know. Did she end up, she did not end up getting it removed. No, I think it's gonna be Monday. Yeah, she ended up going for a sigmoidoscopy for us last night. Poor thing, she had a busy day. Or he was like, I'm not going to St. Mary's now. But that can happen, honestly, in any setting. It's a complication. All right, on the types of pneumothorax, don't worry about all these other ones. Really, the exemplar is the hemothorax. So don't worry about these other ones for our purposes. Hemothorax is, instead of air in that space, there's blood in that space. Treatment is the same. Chest tube is going to be placed. It's going to get rid of that excess, in this case, blood. When there's too much air in the space, the chest tube will get rid of the air and fluid. When there's blood, it will get rid of that blood. We're going to transfuse them if they need to be transfused, depending on how much blood was lost. The tension pneumothorax, this is a medical emergency. This is when the air enters the pleural space. It compresses the good lung. So the patient, if they don't even have the good lung, they are in trouble. This is treated with needle aspiration. It's very dramatic, and then they're going to get the chest tube, but they're going to do a needle aspiration. It's a really long needle. It's kind of a terrifying looking needle. Anybody watch Grey's Anatomy? You've seen it done? You see it? They don't, it's like they get the running start from the door, they plunge the needle in. It's very dramatic. Not that dramatic in the hospital, but it's very dramatic. It's a long needle, and boom, in it goes. They relieve the tension, and the patient comes back, and then they put the chest tube in. It's like magic. Needle decompression and then chest tube. All right, and then these are the signs of the tension pneumothorax, dyspnea, tachycardia, tracheal deviation, absent breath sounds, JVD, cyanosis. Not good, you'll know they're in trouble. And the last thing I want to just mention to you is a flail chest, what we call a flail chest. And this is when somebody has, as you can see in the image on the left, they have multiple fractures. Rib fractures, you know, we don't usually do too much with. There's not much we can do. But in this case, when they have multiple, see how there's more than 2 breaks in one rib, and multiple ribs are affected, they're never going to be able to ventilate properly. This patient has to go to the OR. They're going to use some wires to stabilize the rib cage so that they can ventilate properly. We see this injury with domestic violence usually. This is someone who's usually been thrown down some stairs or slammed to a floor. We do see it with motor vehicle accidents as well. But it's a very difficult surgery, as you would imagine. It's a very painful recovery because even when it's been stabilized with the wires, it hurts them so much to take those deep breaths in or to do their incentive spirometer. So we have to really watch them for pneumonia. They're at higher risk for pneumonia post-procedure. All right, I went as fast as I could. Any questions you guys have?